Hey, how's it going, everybody? This is Timothy Gentry again, a staff paramedic of Cooper University Hospital EMS. Thanks for tuning back in. This is going to be part 2 of our pharmacology review, where we're going to take a focus on cardiac or antiarrhythmic medications. It's a real broad overview. Some of the medications in this category obviously fall into other categories as well, but this is typically our cardiac or antiarrhythmic meds. And just real quick, I want to refresh the objectives. It's to learn the names of the drugs carried by this particular service and their respective concentrations and doses. You also want to familiarize yourself with the protocols or the clinical situations where these drugs are utilized. And I really want you to understand, at least at a basic level, the pharmacokinetics and dynamics, and just kind of reiterate and refresh the pharmacology, anatomy, and basic biochemical concepts that you've probably already learned in your classes. And again, this is part 2. So if you watched part 1, you got an idea of how this video is going to go, but if you're watching them out of order, I did want to refresh the objectives and the assumptions. So obviously, the drugs carried by different systems always vary, whether it be within the same state, different states, etc. So always know your state and your national protocols. The pharmacokinetic and dynamic information that I provide is typically pertaining to the IV route of administration. Obviously, you can give these drugs in multiple different routes, but we're going to focus on the IV route of administration for the majority of them. So if you're looking at the onset or duration on each slide, which I'm not going to read out loud, and you're kind of scratching your head as you're reviewing the slides, more likely than not, it's pertaining to the IV route of administration. And again, these are just broad applications of the drugs. So obviously, if you're using them in the hospital as a nurse, physician, etc., or you're a combat medic on the battlefield, some of these drugs that I list, you're able to use them for multiple different things that I might not list on this slide. Everything that I'm referencing is typically aligning with the pre-hospital environment. So with that said, let's go ahead and plug forward. Just a quick about me, should you care about my previous education and experience in EMS. Again, this is a refresher on it from part 1, and we're moving on. For your convenience, these are all the drugs carried by category, and as you can see, we're going to be tackling the second column here, cardiac and antiarrhythmics. And I say an abbreviated review, but truth be told, it's going to take a little bit of time, but I'll try and keep it as quick as possible. So first up on the list is adenosine. This is a commonly used medication. You might be familiar with it because you've seen paramedics or physicians exercise this as a second route of treatment against SVTs that aren't responsive to vagal maneuvers. And this can be for SVTs, meaning supraventricular tachycardias, which is kind of an all-encompassing term, right? Because any narrow complex or any supraventricular tachycardia can qualify as a quote-unquote SVT, whether that be SVT or AFib. So it also says any re-entrant arrhythmias that require the AV node for re-entry. Typically, it's given rapid push IV. It's given with the first dose being 6 milligrams and then the follow-up doses being 12 milligrams. And on this slide, you can see a nice picture right there of your standard SVT, right? So what you're looking for is P waves are often hidden and they're embedded in the QRS complexes. As you can see here, you can't really make out the P waves. So just a review real quick, it might seem a little bit strange that you hear adenosine, and anybody with any biology background might think, well, I know, I've learned about ADP or ATP, adenosine triphosphate or diphosphate. That's a little bit funky. So chemically, it's a molecule of adenine attached to a ribose sugar, right? So derivatives of adenosine are widely found in nature, and obviously they play an important role in these biochemical processes, such as energy transfer. There's your ATP or your ADP, as well as in the signal transduction, as your cyclic adenosine monophosphate, your CAMP, CAMP. So when we're using that adenosine to cardiovert an abnormal rhythm, it's normal for the heart to enter a ventricular asystole for a few seconds. It's a little bit off-putting, and it can be disconcerting to a normally conscious patient. and they might get these angina-like sensations in the chest, but it really is not uncommon to witness that happen, and people always describe it as the pucker factor, right? So they say, oh my goodness, the patient flatlined, but truth be told, that's pretty normal for the heart to enter that ventricular asystole just for a few seconds. But to put it into picture, right? So you'll have your let's see. So you'll have your SVT, and then you push the medication, rapid IV push, and it's not uncommon to see it enter this asystole before converting, right? And then you get your happy normal, and that's totally normal. Don't let that completely throw you for a loop. All right, back to it. Moving on from adenosine, we're going to move on to aspirin, right? I don't want to spend much time on aspirin. If you're watching this, chances are you're an adult. And if you're not, I don't know how you got onto YouTube to watch this. But anyway, aspirin is such a common medication over the counter. It's PO for pain, fever, inflammation, anti-clotting, etc. More often than not, the reason we're giving it, at least in this EMS system, is we're giving it for suspected ACS, right? Acute coronary syndrome. Anybody who's spent any time in maybe like a Chem 1 lab, you've probably synthesized aspirin. It's made with the salicylic acid and your acetic anhydride, but again, it's really not something worth heavily reviewing. Just know, your side effects are stomach ulcers and GI symptoms, etc. And that it's a platelet aggregation inhibitor. Sorry, wrong way. So moving on, atropine sulfate, right? So you might see this in a couple of different forms and administered a couple of different ways. If you're, in combat, you might see those duodotes that they administer with the atropine and Valium combo, for chemical warfare or what have you. But the reason we're typically using this in civilian EMS is for the treatment of symptomatic bradycardia, right? So it's a non-selective muscarinic acetylcholinergic antagonist. There's a mouthful for you. And what it does is it increases the firing of that SA node, your sinoatrial node, and conduction through the atrioventricular node, your AV node. What you're looking to do is you want to oppose the actions of the vagus nerve by blocking the acetylcholine receptor sites and also it decreases secretion. So sometimes you'll see this given peri-intubation, or just as prophylaxis prior to intubating somebody. Side effects: urinary retention, constipation, dizziness. Nothing too crazy going on there. And I hear a lot of complaints that there's a lot of different anti-dysrhythmic or cardiac medications that start with an A. And a quick dirty trick that I like to do for the cardiac medications, a good way to remember which is you have your adenosine, right? So you're starting with your adenosine, which is AD, and then you have your atropine, right? So AT. Adenosine is AD, which you can, let me undo that. You can say D down. You want the heart rate to slow down, right? Atropine, think of T top. Sorry, my handwriting's atrocious right now. Top. So you want the heart rate to speed up. You want it to be at the top. So just a quick and dirty way of thinking of it is, adenosine, AD, down, you want the heart to slow down. Atropine, AT, top, you want the heart to speed up. You want it to be at the top, it's a quick and dirty way. It's not always applicable, but I think it's a good way to differentiate between the two. All right. So moving on from atropine, we have our calcium chloride, very useful, not often used in the pre-hospital environment, but it is a fantastic drug to carry. Typically, so obviously it's used for the treatment of hypocalcemia or any arrhythmias associated with hypocalcemia, hyperkalemia, or hypermagnesemia. A lot of people get calcium chloride and calcium gluconate confused because hospitals, EMS systems, etc. carry both. And one thing to keep in mind when you are administering this calcium chloride is that it contains 3 times more elemental calcium as compared to that gluconate. So if you're going to blow that IV site, or if you have extravasation, tissue necrosis is very likely. So you need to be careful if you're using that calcium chloride. But a lot of times you'll see us administer this, and a good example is if somebody on dialysis or with you suspect a gross electrolyte imbalance and they're in cardiac arrest, you might use this as a potential reversal you might use this to rectify one of the potential reversible causes of that cardiac arrest for the dialysis patient. So again, great medication, not often used, but a really good one to have in your toolkit. Okay, diltiazem. Again, not often seen or used. It's also called a cardizem, but it is a fantastic calcium channel blocker. Also an antihypertensive. So when you're going to see EMS systems use it is for the treatment of stable narrow complex tachycardia. So more often than not for rapid atrial fibrillation or flutter. And we're usually taking the time to administer this when the patient is stable. Keyword stable, right? So if they are unstable and they're sick, they look pale, diaphoretic, they're hypotensive, we're going to go ahead and bypass the medication route, and we're going to move straight on to the synchronized cardioversion. A good way to think about that is if they're, if they're stable, medicine before Edison, and then if they're unstable, Edison before medicine, right? So anyway, this is kind of complicated, right? So if you think about things at a cellular level, what's going on is this prevents calcium from entering the cell and eventually causing vasodilation and a drop in blood pressure. So we need to, when we're administering this, be judicious with our fluid administration and trending of vital signs. But basically, to quick review it, when it's opening that L-type calcium channel, it allows calcium into the cell, right? And that's going to in turn lead to the release of more calcium from the sarcoplasmic reticulum. When that calcium is going to bind to the calmodulin, and that calcium calmodulin complex then activates myosin light chain kinase, I believe it is. Yeah, the MLCK. And this is important because active MLCK phosphorylates myosin. It phosphorylates myosin, which is then going to result in actin-myosin cross-bridging. And essentially, that's just a long-winded way of saying this controls the contraction of the smooth muscle and vasoconstriction, right? So all really important things when you're considering cardiac medication administration. Again, don't read too much into it, but the short of the long there is that that huge mechanism just results in the contraction of smooth muscle and vasoconstriction. Okay, so moving on from that. And I expect somebody will review cardiology with you, so you can apply these. I don't have to review the actual EKGs of each one of these too much, and that you already have in mind what they're used for and what these dysrhythmias are that I'm referencing. But moving on to epinephrine, huge medication, used often in several dilutions, right? We have varying doses, varying dilutions, and it's an alpha and a beta adrenergic agonist, right? So we can tap into both of those depending on the dose, but naturally, it's a hormone, it's a neurotransmitter, it's produced by the adrenal glands, but we also are able to use it as a drug. It's nice. The dilutions, the common dilutions, and the only dilution that we're using prehospitably is the 1 in 1,000 for anaphylaxis, the 1 in 10,000 for cardiac arrest, and then our 1 in 100,000 as a pressor. And you can see the respective doses next to them. It has wider applicability involving smooth muscle relaxation as well. There's your beta 2 receptors and vasoconstriction, right? So your beta 1, you think about beta 1 versus beta 2. Beta 1, there's one heart. Beta 2, there's 2 lungs. There's a quick word association for you. Anyway, so epinephrine causes an adrenergic receptive mechanism on effector cells, and it kind of mimics all the actions of that sympathetic nervous system. So if you're using it, you're using its action on alpha adrenergic receptors. Epinephrine is basically going to minimize the vasodilation and increase the vascular permeability that occurs during anaphylaxis, which can cause the loss of intravascular fluid volume as well as hypotension, right? So when somebody's in true anaphylaxis, one of the things we're petrified of is hypotension, right? They lose that peripheral tone. We need to fix it. That's when we give that epi 1 in 1,000. We're looking to increase that peripheral tone. We're looking to vasoconstrict, right? Because poor tissue or poor organ tissue perfusion, whatever, is what we're looking to avoid. That's why it's the #1 emergency medication in our anaphylaxis. That's why we're walking around with EpiPens and not Benadryl pens, right? But if it's the beta receptors that you're looking to tap into, its action on beta adrenergic receptors is basically it leads to bronchial smooth muscle relaxation, right? So it helps relieve bronchospasm, wheezing, dyspnea, etc. that occurs during anaphylaxis. So it's useful for anaphylaxis as far as the bronchospasm and the wheezing goes, which you might hear, which you can also administer other medications for. But this is useful for both alpha and beta adrenergic receptors, right? So moving on from that, we can think about the epi 1 in 10,000, which is used in cardiac arrest, and then the epi 1 in 100,000, which is used in cardiogenic or distributive septic shock, any sort of gross hypotension. So just to give you a quick heads up, as far as the dilutions go, it can be a little bit tricky, and truth be told, I'm not even completely certain why it is that they market it as those dilutions, but they're serial dilutions that you're making, right? So when they say 1 in 1,000, they're saying there's 1 milligram in 1,000 microliters, right? And what is 1,000 microliters equal to? Well, it's 10 to the -3, so that's 1 milliliter. So this is useful, right? So when you see 1 in 1,000, it's 1 milligram in 1 ml, and then when you see 1 milligram, when you see 1 in 10,000, you know that it's 1 milligram in 10 mLs rather than 10,000 microliters. And that's also, when you think about your serial dilutions, you now know 1 milligram in 100,000 microliters is 100 milliliters, and we're not carrying 100 ml bags typically when you're drawing up and creating that serial dilution for the presser of the 1 in 100,000. You're doing it in a 10 cc syringe, right? So more often than not, you have now turned your milligram doses into microgram because you only have 10 milliliters of your 100 milliliter dilution. So it now becomes 100 micrograms. 100 micrograms. I had to double check my math on that. And just to review, if you're not certain, I'll do a really, really crappy picture of a serial dilution. What is essentially happening is we'll do a twofold, threefold, whatever. So you have your stock, right? So let's say our stock is the 1 milligram in 1 ml. What we're essentially doing when we create the next dilution, the next in the serial dilution, is it's 1 milligram in 10 mLs. So we're taking 1 milligram from this, and let's say we have saline over here. To create 10 mLs, we're going to use 9 mLs from that, right? So 1 ml from this, 9 mLs for that. Now we roughly have 1 milligram and 10 mLs. And then same thing moving forward in a serial dilution. It's just worth mentioning because there are different ways of making dilutions that have a little more accuracy called parallel dilutions, but we won't dive too far into that because that's getting too far off track. But anyway, just know which dilution is used for which ailment, and this is basically it right here, what you're looking at. Okay, moving on. Next up is lidocaine. Might sound funny because you think of lidocaine, you think of your xylocaine. You're thinking of that local anesthetic, right? If you're stitching somebody up or whatever it might be, you think of the local anesthetic, which it is. It's a local anesthetic, but also we're keeping it on this slideshow, in this portion of this slideshow, because it's also an antiarrhythmic, right? So we're using this for those ventricular dysrhythmias, like wide complex tachycardias, such as ventricular tachycardia, or we use it in ventricular fibrillation, VFib, VTAC or VFib. When we're using medication in somebody who is quote unquote stable, or I should say in a sustained wide complex tachycardia with a pulse, is when, like I've said previously, when they're stable, right? You use medicine before Edison. So we think about medicating them. Essentially what it's doing, and we can dive into it, it's inhibiting sodium ion channels. And that's really important when it comes to resting membrane potentials, and it depresses the action potential phase 0, which makes it, I believe it's a class 1B antidysrhythmic. But just a quick review. Let me quick review what I mean by that, and this might help you better envision what's going on here, right? So let's see. Let's erase this, right? Sorry, it's a little bit tedious. I'm still learning the ins and outs of this whiteboard. And if you can believe it, this is my second ever video recorded lecture. So let's see. Let's erase this. There we go. Bear with me here, people. Okay. So let's see if I can keep this in the screen. And these numbers are just rough, so take it with a grain of salt. But I'm going to make a graph for you here, right? So let's say this is now this is pertaining to resting membrane potentials, right? So let's say this is like negative 80 millivolts, and let's say this is positive 75 millivolts right here. And let's look at our standard EKG, right? So this is actually more so like an oscilloscope reading, but right here we have our threshold. It's moving along, we have our threshold, and then you notice it gets more positive before becoming more negative, right? So there's your depolarization, your action potential. So what's happening here intracellularly is you have all sorts of channels. So you have voltage-gated channels, you have ligand-gated channels, etc., etc. And in each cell, you have two major cations, right? Everybody thinks about potassium and they think about sodium, both intracellularly and extracellular. So this negative 80 millivolts is roughly where potassium likes to live. And then your positive is where sodium likes to live. So think about it this way. As these leak channels are just self-regulating and these other voltage-gated and ligand-gated channels and whatnot, receptors are letting potassium and sodium in and out. As sodium comes in, and this resting membrane potential, which is at a baseline more negative on the inside, right? So it's more negative. As this sodium begins to leak in and it becomes more positive, it reaches this threshold. And once it reaches that threshold, it says, okay, well, that's nice. I'm now ready to make my way up towards the resting membrane potential of sodium, because now I have a lot of intracellular sodium, which is more positive than that potassium. So think of it this way. What does VTAC look like? A bunch of rapid action potentials, right? So inhibiting that sodium ion channel allows for that self-regulation to occur again, right? Because when it thinks that it's constantly, because if there's too much intracellular sodium and it thinks that it's constantly at a more positive resting membrane potential, it's going to try and constantly and rapidly fire its way towards the resting membrane potential of sodium. And then if you inhibit that channel, it kind of allows the prolonging of that action potential phase and allows it to self-regulate again. And that's more or less, that's like a really quick and dirty description of it. It's not the best either. I could probably do a better job, but I just wanted you to somewhat understand why giving lidocaine as a sodium ion channel inhibitor is useful in wide complex tachycardias, right? So we'll go back to it. And there you go, inhibits sodium ion channels. Don't think too much into it. And you can review those concepts later if you'd like to. Magnesium sulfate, so MgSO4, right? Anybody that has worked with thermochemistry, or if you've been in a chem lab and have used calorimeters at all, I put this picture as a joke, but also seriously because it's just Epsom salts, right? Magnesium sulfate is very common, but we were able to use it as a medication as well, which is nice. And more particularly, it's an electrolyte, but we also use it as an antiarrhythmic. So wide applicability. You might see it used to rectify hypomagnesemia, eclamptic seizures, torsade de pointe, or asthma, etc., etc. So what it does is it's going to act competitively in blocking the entry of the calcium into synaptic endings. So that kind of alters the neuromuscular transmission. And I'm not terribly familiar with the mechanism of action, and like I said, it has such a wide applicability. But I do know it's also used for your smooth muscle relaxation, and it's thought to affect the myocardial impulse formation and conduction time, which is where you're going to use it to rectify that torsade de pointe. And if you're just new to the torsade de pointe, that's going to be your polymorphic VTAC, right? So that's going to be your one that that's going to be your one that kind of looks like that. And I'm a poor artist, but you get the idea. And there's your torsades, right? As far as the dosing goes, be careful. I wrote 1 to 2 grams on here, but the dose widely varies, and quite frankly, if you're using it for that eclamptic seizure, it's probably going to be a much larger dose. I would have to refresh, but I believe it's something like 4 to 6 grams in if you're using it for the eclamptic seizures. Moving on to metoprolol tartrate, we're typically stocking this in times of cardizem shortage. It's good. It's a good beta blocker. It can be used on beta. It's a beta antagonist for both beta 1 and 2 receptors, but it's selective for that beta 1 receptor, which is really useful, right? Because we're going to use it for that heart rate control and the symptomatic tachycardias. Think, rapid AFib. It's great. It's going to decrease heart rate, decrease systolic blood pressure, decrease cardiac output, and it's going to inhibit that tachycardia, which is what we're looking to do. Keep in mind though, right? So at high doses, we mentioned it's a beta 1 and a beta 2 antagonist. Be careful, because at high doses, it also has those beta 2 blocking properties. Predominantly bronchial smooth muscles and vascular musculature. So make sure you use it with caution, if at all, in your patients with the history of bronchospastic disease like asthma, because you really don't want to antagonize that beta 2 receptor. You don't want to block those properties in patients like that, and just be wary that it can also cause hypotension, bradycardia, heart blocks, etc. So have your other interventions on standby if need be. Nitroglycerin, very common. Anybody with elderly folks around have probably seen this more than once. It's also called nitrostat. And so I wrote 0.4 milligrams or 400 micrograms sublingual. but also know that we can give it as an IV bolus. Some people might refer to it as tridol, but essentially what's going on here is the nitrates are going to exert their effect by being converted to nitric oxide in the body, right? And that's important because nitric oxide is a potent vasodilator. We're using it for angina pectoris. It's painful symptom. That's a painful symptom. Angina pectoris, fancy word for chest pain, right? But painful symptom of ischemic heart disease, right? So lack of blood flow and oxygenation leading to ischemia, and it's great as a potent antihypertensive. With that said, be careful. Give too much, you can cause that hypotension. But at low doses, typically nitroglycerin is going to dilate your veins more than your arteries. And what that's going to do is that's going to reduce preload, right? So preloads your volume of blood in the heart after filling. And that's thought to be its primary mechanism of action, which is, it's great, right? Because if you decrease that preload, the heart's going to have less blood to pump, which is also going to decrease the oxygen requirement since the heart doesn't have to work as hard. So more or less that's the goal. And then, at higher doses, it can flop and it'll dilate arteries more than veins. But essentially, yes, at low doses, we're looking to dilate those veins and reduce that preload. And we're gonna go ahead and wrap this up with norepinephrine, right? You'll hear it often referred to as Levophed. And so I say 4 milligrams and 250 mLs, and that's D5W or normal saline. It's a sympathomimetic, and it's a alpha and beta 1 adrenergic agonist. When we're using this for cardiogenic, neurogenic, and distributive shock, but please do not use this for hemorrhagic or hemorrhagic shock or trauma. You want to just use it for that inotropic support, and think about the heart as the pump. A heart as a pump, or their vasculature as a pump. If it's empty, making it pump harder is not going to do any good. What you want to do, it's tricky as far as administration goes. It's usually given in a pump and as a drip. More often than not, you're going to see infusions started at like 10 mics per minute, with a max of like 30 mics a minute. And usually you see titration to desired effect, right? So again, great for inotropic support and really useful to have in your toolkit. But that's wrapping it up for the cardiac and the antiarrhythmic medication lecture. And moving on to part 3, we're going to dive into all of the other miscellaneous medications carried on the truck. Thanks.